I'm Drew Dawson. I'm the Director of the Office of Emergency Medical Services at National Highway Traffic Safety Administration. First of all, I would invite you to move up front. We really would love to have you up here. First of all, we can't see anybody back there with the lights, so if you'd like to move up front, we'd love to have you up front. Certainly makes it a little bit easier for us, but your choice. So, yeah, there you go. Thank you.
Pressure's on.
Thanks a lot. Hey, there you go. Appreciate that. That's right. Cool. So I'm just going to ask, first of all, the rest of the panelists to introduce themselves, and then we'll just get started, okay? Chief Gaines.
Good afternoon, Glenn Gaines. I am the acting U.S. Fire Administrator for the U.S. Fire Administration.
Good afternoon, I'm Rick Patrick, the Director of Medical First Responder Coordination for the Office of Health Affairs at Homeland Security.
Hi, my name is Bill Brown. I'm the Executive Director of the National Registry of EMTs.
And I'm George Hatch. I'm the Executive Director for the Committee on Accreditation.
So thank all of you very much for being here, and thanks to the panelists for being here as well. The format that we're going to use today, we're each going to do a short overview, and then at the end of the presentations, we're just going to open it up to question and answers. So it's a little bit of a unique panel today. We have three folks from the federal government, and we have folks from the National Registry of EMTs and from COAMPS as well. So it's going to be a bit of an eclectic approach today, and we're welcome to have you ask us questions, and we'll do our best to answer those questions as we get toward the end of the panel discussion. So first of all, I'm just going to do a very quick run through of the NHTSA Office of Emergency Medical Services. A little bit about us. Some of you may know about us, and a little bit about our history, but I promise you not to bore you with a lot of details. So, our mission at the Office of EMS is fairly broad at NHTSA, and it's basically just to improve the emergency medical services system in the nation. So even though we are at the National Highway Traffic Safety Administration, we've recognized for a long time that in order to improve the care to traffic crash patients, that you require a comprehensive emergency medical services system. The way that we work really is partnerships through accomplishments through partnerships and collaboration. Our office is a fairly small office. We focus on comprehensive emergency medical services development. We focus on working with our partners both at a federal level and our partners at a national level, and really focus on doing agenda-type documents and then implementing those documents and focusing on projects of national significance. We don't have a response role, and we don't have, for the most part, we don't have a lot of grant money to give out. There is some highway traffic safety grant money that is provided, but we aren't a large EMS grant-making body, just so that's kind of known up front. Just a little bit of information about our history in emergency medical services, really going back through the 1960s, beginning with a report called Accidental Death and Disability, which pointed out the tremendous problem with deaths on the nation's highways, and that most of those deaths were, or many of those deaths were attributable to an inadequate emergency medical services system. That really spawned the development of the national standard curricula for emergency medical technicians and eventually first responders. It spawned the development of model state EMS legislation, public relations education manuals in the 1980s, and air ambulance guidelines in the 1980s, going through emergency vehicle operations manuals, EMS agenda for the future, which kind of broadly envisioned the future of emergency medical services in 1996, followed in the 2000s by the EMS education agenda for the future, which outlined a broad vision for the nation's EMS education system. Again, those are all consensus-based documents in which all of, for the most part, 26 different national organizations throughout the United States are involved. The National Emergency Medical Services Information System and the National EMS Database, the Federal Interagency Committee on EMS, and finally the National EMS Advisory Council. A lot of things in between, but that kind of gives you a bit of a timeline and a schematic of our activities over the last 40 or so years. Again, we focus on the entire emergency medical services system. Probably our predominant focus is on the pre-hospital aspect of that emergency medical services system. This is just a graphic depicting the entire system and how we, in EMS, we don't focus as a system. It's not just the pre-hospital focus, but it is the entire emergency medical services system. We certainly work a lot with our partners throughout the federal government in trying to improve the entire emergency medical services system. Examples of some of the current projects in which we are involved, and when I say we are involved, every time I say the we at NHTSA, it is we in conjunction with our federal partners at Homeland Security, at the Department of Health and Human Services, in many instances at the Federal Communications Commission and other federal agencies as well. So it's very much of a collaborative approach that we take with respect to all of the projects that are going on at NHTSA, whether it be the EMS workforce agenda, a national culture of safety project in which we are just embarking, ground ambulance safety projects. We have a program looking at assessment of state EMS systems where we bring a team of experts from outside the state to look at a state's EMS system, compare it against an objective set of standards, and leave the state with some recommendations about improvements of their state emergency medical services system. That's been going on for many years now. Just about every state has had an assessment. Many states have had reassessments. Under statutes, we are also the home of the National 911 Office, a responsibility we share with the U.S. Department of Commerce, and house the National 911 Resource Center, actively involved both with CDC and with other components of National Highway Traffic Safety Administration with advancing automatic crash notification, with FICOMS, the Federal Interagency Committee on EMS, and our federal partners with developing processes for better translation of data and evidence into practice, the EMS education agenda for the future, which we'll talk about in a few minutes, the EMS information system, which actually now houses a national EMS database, and National Electronic Injury Surveillance System for tracking injured EMS workers who are hospitalized. It's a system that we work with our partners at NIOSH with, and it's those who actually end up at a hospital emergency department and who are injured in the line of work. The EMS education agenda for the future, a systems approach, was actually a consensus-based document of the national EMS community. Again, 26 national EMS organizations were involved with the development of this document. It was published in 2000 and provided a broad guideline for how it is that we look at the nation's emergency medical education agenda, the emergency medical services education system. And as many of you know, it has 5 core components, including the core content, the scope of practice, the education standards, national EMS certification, and national EMS program accreditation, all working in sync with the idea of promoting a more consistent and professional EMS education system and enhancing the visibility and viability of the nation's EMS workforce. Things are going well with the implementation of that agenda, we believe. It certainly has been underway for since the development of the agenda in 2000. We rely to an extent on the National Association of State EMS Officials as the folks who are responsible for the licensing and credentialing of EMS personnel in their state. If you haven't visited their website, I would encourage you to do so. There are addresses up there, and you can look at some of the tools and guidelines that they have available on their site to help states and localities with the implementation of the EMS education agenda. A majority of states now either have or will adopt the scope of practice levels for emergency medical responder, EMT, advanced EMT, and paramedic. You have the statistics up there based on a survey from the National Association of State EMS Officials. Most of the states are now using the National Registry of EMTs for at least one level of the scope of practice, and a majority of the states, as you see, already are or plan to require National EMS program accreditation at the paramedic level. Switching from strictly the NHTSA activities to the Federal Interagency Program Coordination, the Federal Interagency Committee on Emergency Medical Services, on which Chief Gaines sits representing the U.S. Fire Administration. The Federal Interagency Committee on EMS was established by Congress in 2005 with representation from 10 different federal agencies, as well as appointed state EMS director. That's all established by law. The purpose of the FICOMs is to ensure interagency coordination among the federal agencies, to identify gaps, to make recommendations to Congress. The Federal Interagency Committee on EMS meets in person 2 or 3 times annually, as well as a variety of conference calls. There's a group of folks, staff level at my level, who meet on my level and Rick's level, who meet by conference call at least monthly. And the staff support to FICOMs is by law provided by DOT, by HHS, Department of Health and Human Services, and by the Department of Homeland Security. Among the current activities are the conduct of a national EMS assessment, really describing where we are in the nation, kind of a demographic assessment of the status of the nation's emergency medical services system. That assessment is, Rick is actually the chairman of the group that is working on that. That will be available for public dissemination. We're looking at kind of the final review of that now. Probably in several months, I would say, would be a good public timeline. We have been assigned a couple of tasks by the National Transportation Safety Board, looking at responses to rural MCIs on roadway and making some recommendations, responding back to the National Transportation Safety Board, as well as providing some recommendations back to them on the utilization of helicopter emergency medical services. The status of those recommendations you can look at by looking at by going to ems.gov. We're in the process of preparing a report on pediatric activities to Congress, and thanks to the Department of Homeland Security, engaging in a more formal process of strategic planning among the federal agencies to assure better alignment of the activities of the federal government and more common strategies among each of the federal agencies. And finally, the National Emergency Medical Services Advisory Council. If you aren't familiar with the ways in which the federal government can receive recommendations, on a regular basis, it has to be something called a formal federal advisory council. There's a certain way in which the federal government can receive recommendations. And the Secretary of Transportation several years ago set up a federal EMS advisory council specifically dealing with emergency medical services. Represents 24 different sectors of emergency medical services. The idea is that this group would provide formal recommendations to us at the Department of Transportation and via the Department of Transportation to the Federal Interagency Committee on Emergency Medical Services. This group meets 3 to 4 times per year, have a variety of different subcommittees. The new chairman of that is Aaron Reinert. Aaron runs emergency medical services in Minnesota, and he has just been appointed as of about a month ago. He took over from Dia Gaynor, who was the state EMS director in the state of Idaho. So with that, I will turn it over to Chief Gaines, and then we'll be happy to entertain questions at the end. So thank you. So Chief.
Good afternoon. Let me get over here by the mic. Thank you for staying so late. I realize it's been a long week. And let me hit escape. Drew, you didn't clean up your mess here.
What's that? Sorry about that.
That's all right. I'm just giving you a hard time.
You still want that?
Yeah, we're going to go black screen here. I want to first thank you for protecting this country. You know, I work for FEMA. U.S. Fire Administration is connected to FEMA. FEMA is connected to the Department of Homeland Security. When folks dial 911, they don't expect us to show up. They expect you to show up. And one of my duties as a U.S. Fire Administrator is to ensure that I recognize the good work that you do and then communicate that to those in power. I'm trying to go to full screen. Here we go. Who have the power to make decisions that affect your daily lives, your organizations, and your ability to be successful every day. So I bring that to their attention. I'm going to need you to take that off here in just a minute. I wanted to just begin by telling you that there's a number of things that the U.S. Fire Administration is engaged in terms of EMS. One, I think, of the more important things we do is studies in terms of the impact of service to man on fire-based EMS systems in this country. All of our reports, all of our special documents are now on Google Books. So you can access anything that I present today in terms of a report or a study. Any updates, any final reports are on Google Books. Of course, they're at our website, but I wanted to bring that to your attention. At U.S. Fire Administration, we also realize the current environment that you're in, you being fire-based EMS. We also realize the stress and difficulties that our fire chiefs and union presidents are faced with every day. Many questions are being asked of you. Everything we do, everything we're about is being questioned, and we certainly are aware of that. What we believe our responsibility is to give you the answers. Tell the truth, provide empirical evidence of the value you bring to the community in an unbiased way, but factual. I wanted to just mention that our role in EMS has been and continues to be focused on fire-based EMS systems, although the information that we present every day, the classes that we present, that we offer, both on campus and off campus, and then through our virtual campus, are open to all. In fact, we just graduated a rural metro battalion chief in the EFO program. So we don't discriminate, although by statute we have been directed to focus on fire-based EMS systems. What I want to do is get through a few slides and talk about some of the important research. So what we'll do, there it is. All right, let's go to the screen. I will just remind you that we have 10 and 6-day classes, residential classes that are open to anyone who is interested and applies. We have 2-day classes that are handoff classes to the state fire training directors. We're also working in blended learning classes so that right in the fire station while you're on duty, you can take these courses through a blended learning approach. And last but not least, we are working in 2 exciting areas. One is taking advantage of mobile technology, some of which you have sitting in front of you today, where we can give you vignettes of information that's important, that's current, things that are happening right now that need to be brought to your attention. And then last but not least, we are working in the area of interactive training using Adobe Connect, where you can actually, we'll bring the Emmitsburg experience right to your fire stations or out to your academies. All right. Several things, as I mentioned, we are working on right now. In our 2008 reauthorization, we were tasked with enhancing the level of training that we're providing to EMS and also the amount of training that we are providing, including studies into the risk, injuries, the impact of infectious disease, and also successful models that are available out there. I'm going to run through just a few of the reports that I mentioned at the outset that are available both online and through Google Books. Emergency Incident Rehab, of course, is something we partner with IFF. Basically, we funded that report, and that was issued actually by the International Association of Firefighters. The respiratory disease for the fire service really focuses on what you should do if you are affected by a respiratory disease. The steps you should take, your rights as an individual, and also the responsibilities of the organization. And in addition, of course, we discuss universal precautions that must be taken. While I'm on this slide, I want to bring to your attention, there are several, and maybe Rick might want to talk about this. I hate to put you on the spot, Rick, but there are several infectious diseases that are reemerging. One of them is dengue fever in the southern states, which is borne, I believe, by mosquitoes. I also learned recently that one of the four antibiotics that are used to treat TB in many cases is not effective. So this is the kind of information that we believe we need to get to you using mobile technology and other avenues rather than produce glossy reports. I mean, they're great, but they get antiquated in this current environment that we're living in. We are working with and funding a cancer study of up to 30,000, that will include up to 30,000 firefighters over 5 to 7 years to once and all put to bed this question whether cancer is indeed, the numbers of cancers in the firefighter demographic is indeed related to this profession. We are looking at both Metro Department, Chicago, New York, LA, others, but up to 30,000 firefighters. We're including rules and also volunteer. We're looking at personnel who have died back in as far back as the 60s to again look at the types of protective clothing through various demographic of firefighters to see what impact that had. As we begin to receive data, we will certainly get that out. By the way, this is also in cooperation and in coordination with all of our partners, IFC, IFF, National Volunteer Fire Council, International Association of Black Professional Firefighters, and others. Improving apparatus roadway operational safety for the career fire service. This is also a program that is available online. I would remind everyone in the room that up until about 3 years ago, fire deaths in firefighters occurred at number 3 in terms of responding to, while on the scene of, or returning from incidents. The number 3 cause of injury and death in firefighters. Through a variety of mechanisms, we have that down 35% over the last 3 years. A lot of that credit has to go to IFF, the IFC, and others who have partnered with U.S. Fire Administration to get at this issue. In the volunteer service, it is especially troubling to see that most of the #1 cause of death, accidental death in volunteers, is when they're responding to the fire station in a private vehicle. So we're taking that on as a special project. You know, our budget is relatively small when in comparison with the federal budget. So one of the things that we do at U.S. Fire Administration is to leverage other federal agencies, also our non-governmental organizations, to produce studies and also reports, and then this particular one, which probably won't run, but it is a public safety, I'll go back, it's a public PSA that is playing on, that is available free of charge, downloadable, either on our website or on the Justice Department website, and actually in several states. Basically, it is a 30-second video that reminds the public that when we're out on the scene working, two things: slow down and pull over. We use police officers, the highway department personnel also join in this video. It's very effective. It's free, and a lot of the stations, local stations, are playing it. This particular report that was issued about 6 years ago has been pulled off. We're updating that, looking at new models for ways that you can raise money and also, again, prove the value of fire-based EMS systems. The EMS Medical Director's Handbook, I think that was presented here earlier today, so I won't spend a lot of time on that, but that also was in cooperation with the IFC and IFF. We also have partnered with Rick to look at mass casualty management and what are some of the best programs, best model programs available to meet that challenge. The Emergency Vehicle Occupant Safety Study is something that we funded beginning about 3 years ago, looking at methods that can be used to stabilize both the patient and the EMT in the back of the unit, looking at both T-bone crashes and also, of course, forward compression accidents. These are two individuals that lead our effort there. This is their contacts. I'm going to make all of the slides available to Lori. So what I would encourage you, if you have questions or concerns in terms of any of the reports that we have available on Google Books or on our website, if you have interest in any of the PSAs we have in terms of, or any of the information we have, any of the coursework we have online, you can dial these individuals, but you can always dial our main number or go to our website. Our policy up there is to get back to you in one business day if you have questions. I would end by just saying we would encourage you to come to Emmitsburg. As I said, we have 2-day, 6-day, 10-day residential courses. It's a great opportunity for you as an individual and also for the crew members that you work with and the citizens that you protect. So thank you, and I'll be happy to answer any questions that you might have. And I'm going to minimize this. Go on, Rick.
Chief, we're going to defer questions till we're all done here, and then hopefully give you the bulk of the time for your questions. Good afternoon again. I'm Rick Patrick, and as I mentioned earlier, I work in the Department of Homeland Security Headquarters Office of Health Affairs, and Essentially, there's going to be some slides come up here. I'm not going to stand here and read slides to you, just kind of highlight some of the areas I'm talking about so you understand where we're coming from as it relates to health, safety, and emergency medical services as a whole. You know, DHS's vision, you know, is somewhat self-explanatory by its mere existence and its creation not quite a decade ago. And the Office of Health Affairs mission is essentially to address all things health and medical for the internal workforce of over 200,000 personnel in Homeland Security, as well as support all first responder assets, both traditional and non-traditional, within the operations of Homeland Security issues. And what this slide here is depicting essentially is we in our office are the intersection between health and health security where it meets national security. So that's essentially the intersection. And my boss, Dr. Alex Garza, is the Department of Homeland Security's Chief Medical Officer. He's Assistant Secretary, which means he's a presidential appointee, but the Chief Medical Officer is the real critical part here because he's the direct advisor to Secretary Napolitano and to the Administrator of FEMA, Craig Fugate, on all things medical. So again, he's a direct report to the Secretary, and for EMS specifically, and this group here, I think it sends a loud message that we've got some pretty direct ears on EMS issues, at least within the DHS side of the house, both through Chief Gaines in the U.S. Fire Administration and all our colleagues at DHS, but to have such a high-level input as well, and I can assure you the Secretary is engaged in the topic of emergency medical services. It's definitely near and dear to her heart. And as you can see from the core operational goals that the Office of Health Affairs have specifically, but just focusing on number 3 on the screen, it's to enhance national and DHS medical first responder capabilities. So that's a high priority goal within our office, and I'll explain both of those here in a little bit, a little more simplistically. I'm not going to spend a lot of time on the other 3 goals themselves. But this slide here really depicts where Office of Health Affairs in the central is the health medical liaison and advisor to all the DHS components that are in the kind of CD looking side of the house, and some special direct links to those outside that sphere. It doesn't deteriorate, it just grows to show the impact of the involvement of the 200 plus people that work in our office dealing with everything related to medical. It's not just EMS, it's health as a whole, it's agricultural, it's veterinarian, and it's food as well. So we're covering the whole gamut from that perspective. So I'm just going to back up for a slide for a second here just to show you the breadth of that. We have 2 divisions essentially in the Office of Health Affairs, one that deals with health threats specifically and health resilience, and the majority of that is focused on biosurveillance, BioWatch, so all things biological for the most part. It is one of the largest portions of our office. Health Affairs owns all the sniffers and other interesting devices and systems that exist in all UASI cities in the United States, as well as a number of other areas. And then in Workforce Health and Medical Support Division, there's essentially 2 major branches. There's one that deals with workforce health itself within DHS, and then there's the other, which I have the privilege to lead, and that's dealing with all assets, emergency medical services, both in-house to DHS, as well as being an outreach person, such as what we're doing right here to integrate DHS a little bit more on the health, safety, and emergency medical services side, but also listen. I've been sitting in a lot of the sessions that have been going on here this week already, and basically just hearing what's going on and identifying gaps and issues, and that's how we enhance some of our collaboration with areas that I'll reference, highlight in a second here, that Chief Gaines pointed out, to collaborate and help fund, if you will. Although we're not a granting agency, we do have funds that we can address gaps, and the goal really is to identify them and then figure out how we can bridge them. You know, sometimes we can close them, sometimes we have to build bridges, but anyway, as long as we're accomplishing the overall goal. With that, we do host a number of work groups where we bring your colleagues and colleagues from all of health and emergency management and EMS to the table. A couple of them are at the bottom there of the screen dealing with pandemics such as the H1N1, where we got real lucky, to put it simple, a couple years ago, but by no means is out of the question to have a rebirth, whether it's avian flu or some other type of a flu from that situation, but anthrax being a major one as well. The anthrax specifically, we're actually pretty anxious that pretty soon the Office of Management and Budget Management will be releasing the medical countermeasures for first responders document. It has been submitted in its final draft form to them for their approval, and that'll definitely, I hope, positively impact the first responder community as we look at resources to provide medical countermeasures should there be an unfortunate attack using a biological such as anthrax. So those are just a couple examples. As I stated, we are an outreach program as well in our office, so we do participate as much as we can with all the NGOs and engage them. And Chief Gaines referenced a number of projects at the U.S. Fire Administration. You might have seen on his slides, I think some of them referenced the Office of Health Affairs support. We coughed up the statement of work on gaps we identified and then coughed up the money to fund it, and then engage the U.S. Fire Administration and other federal partners to carry those out. So I'm not going to go through each one of those again, but some of the current one that the IAFF is working on the EMS health and safety study is one example of those. And then the FICMs, as Drew was referencing, DHS is a legislated or statutory partner within that. My boss, Dr. Alex Garza, is the current chair of FICMs this year. That rotates every year. I believe next year is Kevin, Dr. Kevin. Kevin's last name? I forgot his last name. Yeski, sorry, will be the chair next year, and Chief Gaines sits on it as the U.S. Fire Administrator as well. And then we have a lot of interagency collaboration that goes on in DHS. The 12 on the right side of that screen means there are at least 12 entities within the Department of Homeland Security that play in emergency medical services related topics and issues. They're not operational, but they're dealing with things that affect what you folks will encounter out there on a day-to-day basis. Everything ranging from science and technology, who actually is doing sessions here, every morning pretty much this week with your conference, among others, in the research and development side, to the government's coordinating council and emergency services sector, just to name a couple of them. So we work to collaborate and coordinate all those assets out of my office within Homeland Security as well. And again, partnering with FEMA and the U.S. Fire Administration at the National Emergency Training Center, but also at NETC is the Emergency Management Institute as well. And then down in Anniston, some of you may have been to Anniston, Alabama, at the Center for Domestic Preparedness. They have a plethora of EMS-related programs down there, including HOT programs as well that involve the integration with hospital systems, as well as strictly pre-hospital related situations when some of the real funky things, if you will, start to occur. And then the last major area that we work within is the DHS EMS system itself. DHS operates the second largest federal EMS operational system. For that, and our office at Health Affairs has oversight to the 7 core operational components. Within that, we have well over 3,500 EMTs and paramedics that provide pretty much dynamic emergency medical services as a secondary portion of their law enforcement responsibilities on a regular basis. And we run an EMS system with a plan like many states, or most states do as well. We have an official at the bottom, what that's referencing, the Emergency Medical Services Training Advisory Committee, is a official DHS advisory committee that meets on a bi-monthly at minimum basis and reports directly to the Chief Medical Officer of DHS on all things EMS for his advisement and direction to go forth. And this slide here is depicting some of the things that our system has produced for our EMS operational system, and I show that to you specifically under such as the protocols and the like, because we're in the process right now of formulating some of the medical protocols, especially the special operations protocols related to CBNRE and some other ones for general use by the first responder communities as well. So that's going to be an outreach project, not just for the internal DHS assets. So anyway, in a nutshell, that's a little bit about what we do from my office's perspective, and now I'll turn it over to Bill Brown.
Good guy.
There you go.
Now, let's see here. Well, thanks. It's a pleasure to talk to everybody about the National Registry. We are a non-governmental agency, pretty fairly large footprint in EMS, and I'll talk to you about that as we move along. But it's a pleasure to speak to everybody. My dad was a professional firefighter for 32 years and passed away about 5 years ago. But I can tell you that it was certainly an honor, and he had many, many stories about his life in the fire service, one that he loved. I'm going to give you a small orientation of the National Registry. Purpose of the National Registry, or the purpose of licensure and certification, is to protect the public. So we don't provide a license. The license is provided by the state. The state can make a number of decisions regarding how and what requirements they're going to be for licensure. One of them is certification. Certification really means that that individual has met the standards set up by that organization. What are our standards? Those standards are based upon entry requirements, have to successfully complete a program, be 18 years of age, have CPR courses, etc. You have to complete examinations, both cognitive and psychomotor. And then inherent within certification is a recertification program that has to also be standard set. This is the mission of the National Registry, to serve as the National EMS Certification Organization by providing a valid, uniform process to assess the knowledge and skills required for competent practice by EMS professionals throughout their careers, and by maintaining a registry of certification status. That is a lot of words. Each one of them has a unique meaning and important part of our mission. We are the certification organization, the National EMS Certification Organization, recognized by the National Association of State EMS Officials. We provide valid, a big word for the registry, strive in every way possible to validate every single rule, policy, test item, everything that we do, so that we can deliver it in a uniform way. Uniform is a tricky term. 50 states, 50 different rules, 50 different legislatures. We have to try to be uniform with all 50 states. Many times they agree with us, on occasions they do not. We assess the knowledge and skills. So we do the knowledge by a written examination, the skills by a practical. We do not assess the affective domain. So you may run into a nationally registered paramedic that has a lot of knowledge and skills and a crappy attitude, because we don't assess attitude. So there is, by the way, not an affective domain measurement instrument that's out there that's been validated. Competent practice, if you would ask me what is the National Registry standard, it's competency to safely and effectively practice. EMS professionals, we don't really name those. Those come from the EMS education agenda for the future. The National Registry does not issue a certification for a lifetime. It issues certification for a 2-year time period, and then you have to meet recertification requirements every 2 years. And then obviously we maintain a registry. The registry's been around since 1970. During our time period, we've certified over 1.4 million EMS workers in the United States. Right now there are 370,000 plus registered EMTs in the 50 states. We have a budget of about 13 million, of which 7 million of it goes to Pearson VUE for seat time while taking the computer adaptive test. The registry is run by a board of directors. We have a full-time staff, and we operate our business by a strategic planning process. The board of directors has 5 officers, a chairman of the board. The current chairman is Pete Glazer. He's a pediatric emergency physician from Alabama. Vice chairman, treasurer, and 2 immediate past chairs. All of these people are very visible in EMS. There are 5 physicians on the board. 1 nominated by ASAP, 1 nominated by NMSP, and 3 physicians at large. They're all very active EMS physicians. There are 3 organizations that nominate people to our board: the IAFC, the AAA, and the National Association of EMTs. 3 state officials sit on the board, those state EMS directors, and 4 at-large EMTs, one of which must be an educator, and 1 public member, and we have about 14 liaison organizations that attend our board of directors meeting that meets twice a year, typically in Columbus, Ohio. On the staff, we have about 31 FTEs, 5 people are in administration, 12 of them are in certification and recertification, 5 people develop the examinations, 6 people work full-time in information technology. We have about $2 million worth of source code that's developed solely for the National Registry that keeps our registration, re-registration, testing, and all of the other information in our database. And then we have a community relations and research department that has 4 people in it as well. Last year we examined over 142,000 EMS providers. Most of them took a computer adaptive test. It's the state-of-the-art process. We follow the same algorithms as the National Council of State Boards in Nursing, so it's a very complicated, sophisticated process. It allows, because it's delivered in Pearson VUE centers, that we get next day results. They're downloaded to state EMS agencies. So we set this up so that the system, so somebody can test on Monday, get the results on Tuesday, and have those results delivered to the state EMS office on Tuesday so they can issue licenses within their process as fast as possible. It has great psychometrics behind it. That's the psychology or the measurement of the human mind. Very sophisticated process and a lot of security behind it. We recertify about 85,000 people per year. Those are done by a variety of requirements. You can take the examination for recertifying. You can also do it electronically or by pencil paper. We have a big customer service demand. We answer about 550,000 phone calls a year at the National Registry. If you ever call during the last week of March and you get a busy signal, that means one thing: we're busy. There's about $2 million in computer code. It takes a lot of programmers all the time, every day, working on this, enhancing our system. I've had many, many meetings with providers, educators, state EMS officials to enhance our system, and we always have needs to work on that system. It's a monstrous project. The registry is accredited by the National Commission for Certifying Agencies. We've had an outside review of 21 standards and essential elements. They deal with governance, the organization structure, and finances. About 15 of those deal with the actual test, the measurement instruments, how you develop the test, how the items are put together, the practice analysis, a lot of different things. And there's also a couple standards on continued competency and recertification. All of the National Registry programs are accredited by the National Commission for Certifying Agencies. 45 states right now use the National Registry at one level or another. Some have intermediate programs that don't match up with national standards. They may have enhanced their intermediate to a level beyond where the registry has a test that meets their needs. Some states use the registry at the paramedic level, but not at the basic. The 5 states that do not use the registry are depicted here in gray. That would be Wyoming, Illinois, North Carolina, New York, and Massachusetts. The rest of them use it at least at one level or another. This is about how many registered EMTs, this is about a year old, that are in each one of the states. As you can see, they are all across the nation. The Board of Directors of the National Registry is committed to the implementation of the EMS education agenda for the future, a systems approach. Drew Dawson spoke about the work that's been done on that agenda since 2000. It's been reflected in the Institute of Medicine's report and a number of other agendas supported by many, many national EMS organizations, and our Board of Directors is committed to implementing this. So we are going to follow the National EMS Scope of Practice model. This means beginning in January 2012, our tests will be over the new EMT level. We're putting in processes in place through working with the state EMS officials to transition all current providers. If you are nationally registered, you'll be getting a newsletter that specifically speaks at your level about what is necessary to do. We're allowing 4 to 6 years for these transitions to take place so that we're all on the same sheet of music in all the 50 states around the nation as a part of this transition. Our board of directors in 2007 passed a motion to require accreditation at the paramedic level by 2013. As far as we know, I just received a positive report from one of the states that was kind of waffling. We think all 50 states will be implementing accreditation. Some of them asked for a little bit of a variance beyond 2013 due to economic conditions, and we're working with the state officials to find ways to do that. No paramedic that's out there right now is affected by this. This accreditation is for future paramedics, people that are in high school or not even involved in EMS, or perhaps maybe even basic EMTs. So this will take place in 2013. The registry, according to the agenda, is to respond based upon a practice analysis. When we do our next practice analysis in 2015, there'll be some changes on our examination, which we will be notifying everybody about in plenty of time so they can change their education programs. Again, that's a 2015 kind of a concern. We're looking at changing our recertification requirements more to allow more work at the local level, individual assessments, and national requirements. We did have members of the IAFF on that committee that looked at those recertification requirements. So that's a quick overview of the National Registry. George, you're next.
Thanks, Bill. Howdy, everybody. I'm George Hatch. I'm the Executive Director for the Committee on Accreditation for EMS. Apparently, I got promoted to either being from Maryland or I went to medical school over the weekend, so that's what my name tag says. My job is really to kind of talk a little bit about the accreditation efforts of our organization. And much like Bill talked about a moment ago, the COA EMSP is a 501c3 national nonprofit group. We're in the business over the last 34 years to look at standardizing the educational efforts and the accreditation, the conduit, if you will, the accreditation efforts for paramedic education programs around the country. So you can kind of see our acronym here. We do work in cooperation with CAHEP. CAHEP is the accrediting agency. CAHEP stands for the Commission on Accreditation of Allied Health Education Professions. And they are the actual group or body that accredits the paramedic programs. We kind of do the heavy lifting. So we represent a lot of different EMS subspecialties, and we'll talk about that in just a moment. But from CAHEP's perspective, the COA EMSP is one of 22 different COAs under their umbrella. And our primary response is to simply look at the paramedic education. We changed the name of this organization sometime back in the early 90s to reflect what the EMS education agenda talked about, to be more inclusive, to look at all levels of the EMS professions. But that's really not where our focus is. So if there are people in your particular state, back in your department, that have concerns that this trickle-down effect would look at, for example, first responders or EMTs, that's not what the COA is in the business to do. So we're focusing strictly on paramedics, and as Bill mentioned, this is not going to impact anyone like myself or anyone here that is a paramedic currently. It's going to be impacting those kids that come through a paramedic education program in the future after January of 2013. We are the professional body that makes a recommendation for accreditation status to CAHEP. So once All of the site visit has taken place, and the findings letters go back to the program, and there's a sort of a back and forth dialogue. This comes to the board level, and the board looks at this. They are divided into 4 smaller groups of the body that we currently have, which is 26 individuals, and they spend a good deal of time looking at individual programs and then making a recommendation, citing programs for areas where they have some deficiencies, recommending ways that they might go about looking to fix that, but then making that recommendation finally to KHEP. They also are responsible for providing the language that is utilized in the KHEP standards. If you look at the standards and guidelines that are published, you'll notice that this template looks very, very similar to the other 22 allied health professions that are under KHEP's umbrella. But the language is specific to the EMS profession. So we will be going back in 2015 and we will be revising those standards. So look forward to that. There are 13 sponsoring organizations. I'm glad to tell you that you can see here on the left that there are a number of physician organizations that have been involved since the very beginning of the JRC, which was the Joint Review Committee for the EMT paramedic back in the mid to late 70s. Those include the pediatricians, the cardiologists, the emergency physicians, the osteopathic emergency physicians, the surgeons, the anesthesiologists. Pretty much everybody on that side of the house is represented at our board table. They send 2 representatives. You'll also notice that we have the American Ambulance Association, the International Association of Fire Chiefs. Those 2 groups joined us 2 years ago. And as you'll notice there at the bottom in blue, you guys are looking to join our board of directors as well. You have petitioned our organization, and at the board level, the 13 different sponsoring organizations that currently sit there voted unanimously to allow you guys to come into that process. But now the clock's kind of ticking. They have KHEP has a 1-year time frame that they look at sponsoring organizations being added to specific COAs. So these folks, mostly on the EMS side, we've gathered most of those response letters. They've come back. But when you get into the big colleges, the American College of Cardiology or the American Society of Anesthesia, it takes a little bit longer to go through their legal system to get that back. But we anticipate that you guys will be joining us sometime in 2012 as a sponsoring organization. The vision of the COA is to be the single national accrediting agency for EMS as defined in the EMS education agenda for the future. And our job is to continually improve EMS education by recognizing the full range of EMS professions. So again, stay tuned to that. I mentioned that KHEP is the Commission on Accreditation for Allied Health Professions. They're the largest, not the only, but the largest single accreditor in the health sciences field. They accredit more than 2,000 programs in 23 health science occupation. EMS is just simply one of those professions. What is accreditation? Again, I just want to kind of hit a couple points here. The job here is really about looking at the program based on a standard. So do we have fire-based programs that are accredited? We absolutely do. Do we have private schools that are accredited? We absolutely do. Do we have colleges and universities and hospitals? We absolutely do. We even have one military program, at, the Joint Special Operations folks at Fort Bragg, who have an accredited paramedic program. So our job from the COA at the professional level is to make sure when we go in, not only do you write about your program and talk about it, but we go in and actually verify that what you say is what you're doing. We're measuring your program against a standard. So it's not based on what somebody else 2 towns over or 1 other state over is doing. We're looking at how your program addresses the standards. And there's a lot of different ways that you can go about doing it. So we don't think that it's a one-size-fits-all opportunity. Again, our job is to assure that those standards are being met. We're making sure that the workforce that we're turning out or that a paramedic is moving into is well prepared, that they are educated and they are qualified to provide emergency medical services to the folks in their community. As Bill said, the National Registry's job is to protect the public. Accreditation has a role in protecting the public also, but primarily the one big thing that accreditation does is it protects the students. So nobody's generally at the table protecting students, but that's a big thing in education. And certainly from an accreditation standpoint, that's one of the opportunities that, that we have to make a difference. So just quickly, here's what our process looks like. I can tell you that it's very, very streamlined compared to what it was several years ago, but the big bulk of what has to happen is you've got to write a self-study. And this self-study is written based on the standards. We have a lot of information out on our website today. We even actually have a self-study document that would show you sort of step-by-step what this would look like. When I did this in Houston, where I had the privilege of teaching Houston Fire Department for about 25 years, when I did this self-study for us back in the late 1980s, we didn't have any documentation. The internet, of course, wasn't out there as big as it is today, but there were not a lot of resources. So you kind of had to do this blindly. And I like to think that many of the tools that we have available today are going to make your job easier, or folks that are in your area make their job easier as they go about putting this together. So the bulk of this is going to be based on how long it takes you to put your self-study together. There is an executive analysis that is rendered. So when you send it in to us, it gets cataloged, we read it, we turn that executive analysis around, it goes back to you. Instead of just going to the site visit team, it goes back to you so that you can kind of see these are the areas that you know you're going to have to work on. The self-study report is done by the site visit team on site, where they'll spend 2 days looking at all aspects of your educational program. They will leave you with an unofficial report. The report comes back to us. We're going to kind of knock it around a little bit, make sure that everything is as it's supposed to be, answer any questions that may have not been as clear with the site team. And then once we've got that done, we're going to send back a findings letter. The findings letter will be the official document that comes back to the program, and it will tell you these are the areas that you're going to need to work on. These are the areas that you're doing very well on, but these are the areas that we're going to cite as having an issue that needs to be corrected. Again, our job here is to make sure that the program is in compliance with the standards. Once all of this information is gathered, the findings letter goes to you. You have an opportunity to respond back with the findings letter about what you agree with or what you don't agree with, and you provide evidence if you have evidence to show that, hey, we missed something, we overlooked something, and we want to correct that. Once all of that stuff is done, it goes to our next board meeting. As I mentioned, we'll divide our board members up into 4 groups, and these 4 teams made up of about 4 or 5 individuals, 6 individuals, will take a look at the programs, and they may have 14, 15, 25 programs that they review. We have 2 face-to-face meetings a year where the board comes together and they do this work. We have 2 teleconferences where we do a lot of this work that's in preparation for the board meeting. So most of the heavy lifting of this has been done. They make a recommendation to the full board. The board then acts on that, and then they pass that decision on to KHEP. So that's, in a nutshell, what happens with the accreditation process. How long does it take? Again, the big outlier is how long it might take you to actually get your self-study done and sent in to us. I can tell you that we had 57 new programs that came in by December 31st of this past year. And we processed in the first 3 months and 1 week, we processed those 57 programs. We now have them all assigned for site visits, and things seem to be moving along. So we anticipate that we'll have more interest here as the January 1st, 2013 deadline approaches. You'll do this self-study process with a site visit once every 5 years. So just as Bill pointed out, that national registry or registration is not for forever unless you continually kind of go back and make sure that you're doing what you need to do. This is a similar process. It's a continual quality improvement process. Currently, we have 264 accredited programs in 44 states. Currently, we have 3 programs in Arizona, actually 4 programs that are in Arizona pending. We've just finished a site visit on 2 of those programs, but we currently do not have any accredited programs in Arizona, Hawaii, Maine, Rhode Island, Vermont, where they have no paramedic programs, and West Virginia, where we have 1 pending. We will conduct 120 site visits in 2011, so we have had a very busy year. That includes those 57 new programs that we have. 67 programs are being visited for the very first time, and we are doing 50% more site visits than we did in 2010. This can kind of give you just a graphic of how much business or how much of an increase in business we've seen over the last couple of years. So we had a big spike, and we anticipate that that spike will get larger in 2012. As Bill mentioned, and as Drew mentioned, the registry's decision was based on a lot of information. They talked to all of their communities of interest at the national level. One of their biggest communities of interest, I guess, is the NASEMSO. That's the state EMS officials, where those folks were asked to place a dot on a map and basically say, when do you think your state can meet this requirement? So after all of that stuff was placed out there, and they've gone back to this over the last 3 or 4 years now, the decision was made back in October of 2010 by NASEMSO, where they supported the deadline of January 1st, 2013 for the beginning of national registration at the paramedic level to graduate from an accredited school. So that's kind of the history. Are we ready? I think the answer is yes. We've spent the last 4 or 5 years now. We've increased our staff. We have developed online tools. In fact, before, where you would actually produce a 5-inch notebook, make 4 or 5 copies of this thing, put it in a big box, and send it UPS or FedEx to our offices, all that stuff's over with now. You can now send all of your information in a flash drive or on a CD. And in fact, we've actually made it even better than that, I think. We actually have the opportunity for you to upload your entire self-study to our database electronically. So it really completely eliminates the need for you to put something in the envelope and send it to us. We're writing articles about accreditation. We had one that was just published in EMS World about the accreditation process. Mike Smith did an article. We are offering workshops. We've done 3 workshops, or 2 workshops we've completed this year, freestanding workshops. We'll do another one at the NEMC conference in Reno in a couple of weeks. We have one more that will be done in Atlanta, Georgia, the 2nd week of November. And we anticipate we'll have 3 or 4 of those next year as well. We're also doing webinars. Those webinars are archived. They are on our website. And if you're interested, we kind of break down each one of the standards and talk a little bit more about it. We've also trained our own new cadre of site visitors to make sure that we've got enough folks to get out there. So with that, I've got my contact information up here. I'm going to turn it back over to Drew.
Okay, now thank you all very much for great presentations, and for the audience for hanging in there. And we'd be happy to entertain questions. I'm trying to figure out what the best way to do this is. I think we'd like the questions, if we can just pass some microphone around, is that? You either come up to the microphone, or we can pass this one around. For any of us. I'll just kind of moderate here, so feel free. I know some of you must have questions or comments or.
I have a question for Bill. Bill, for the National Association of EMT things, is it a nonprofit? Is it a for-profit company? What is it?
Yeah, it's a non-profit 501c3.
I know you explained how as a standard for everybody, but every state has their own requirements. So what's the purpose of setting standards? We want to have a set standard. I'm just trying to understand this. A set standard when every state has their own standards to begin with. So is it not repetitive? What's the purpose? Is what I'm trying to figure out.
It's providing the uniformity between all the standards. So let's use this example in North Dakota. You're allowed to be an EMT at age 16. So what happens is the registry allows those people to take our exam, but we do not register them. We just report a score to the state so they can give them a license. So sometimes the legislature will pass an interesting rule about convicted felons, and the state will say, we can't take them. The registry feels like, oh geez, we could have, but since the state can't, we're not going to take them either. So that's where we get into these little differences. Some states, by the way, have 3-year licenses. So a guy's got a recertify the registry every 2 years, with the state every 3, creates a bunch of confusion. But there's all these little twists that happen. What we try to do is just do the same for everybody in all 50 states. But sometimes the EMTs get confused and the legislatures put different rules in. So that's where we're a little bit of difference there.
So I guess let's say I was a paramedic student and I just say, I want to be national registry. What is it going to do for me? What would being national registry do for me if I got to go, regardless of what state I have to go to, I'm going to have different standards. What's the purpose of having it?
Yeah, well, I'm not saying different standards. I think the registry is used for reciprocity in 49 states. The only state that you have to take their state test is Massachusetts. Right. Because Massachusetts has, this is what they told me, I don't know, they have a test that they have to generate certain numbers to meet their vendor's requirements. So anyways, you have to take the test in Massachusetts. The rest of them, Florida's a little bit different.
The majority of all the states required you to take things like reciprocity for a year or something.
Right.
You still had to take their test on top of it.
I don't know if that's true. I don't know how many states have a supplementary exam. Those are really hard to validate because of the size of the domain that they're measuring. And no one's reported to me about a lot of states having different tests that they have to do besides the registry.
And now you guys are accredited for who?
National Commission for Certifying Agencies.
Okay.
So they don't do just health organizations. There's you can look on their website. I think there's probably a couple hundred different certifying agencies that are accredited by the FCCA.
So I guess you guys are kind of the middleman then between them and the states for accreditation. Instead of going to them directly, we're going to you guys now to be accredited. Is that?
Well, what happens? Accreditation is an outside validation of what we're doing meets the Education and Psychological Association standards on testing. And so somebody's got to come in and say, you could say I do it, but that's you saying it. So what happens is this outside organization came in and looked at our stuff and our processes, and George was talking about our things about this thick when you print it out on paper. We have to explain every process and every policy and rule and everything in the registry. And they said this is credible, so they awarded us accreditation.
So if I could maybe help explain just a little bit as well, just to reemphasize a little bit what Bill said during the presentation, the purpose of the National Registry is for certification to verify competency. That is used as a part of what a state would use to license an individual. So because you're nationally registered, and I know you know this, but because because an individual is nationally registered, that does not give them the ability to practice as an EMT anywhere. They still have to be licensed as an EMT in the state. So it's kind of the common denominator that states would use as a basis for licensing. So if you go from state of, I used to be in the state of Montana as a state EMS director, for instance. So if you go from the state of Montana to the state of Idaho to the state of California, as a for instance, the common denominator would be the National Registry of EMTs to use as a basis for licensure. So you as an EMT, if you were moving from state to state, you would have meant the minimum entry-level competency. Yes, there might be some things you need to do to meet that specific state's requirements, and yes, you would have to be state licensed in each state to which you would go, but it does serve as a common denominator. In some ways, it is not dissimilar from what a physician or a nurse or others would have to do in order to be state licensed. The idea is to have a common denominator on a national level as a basis to grant the permission to practice. I'm not sure if that helps, but.
So if I was at some of my students, they were asking about it. If they're not given a state, if they're just, this is the state I'm going to be certified in, and I'm never leaving the state, then it's really no purpose for them to be nationally registered. If they're not leaving.
But I think part of the idea is it also serves as a standard of care, a standard of competency against which the state can judge the performance of individuals, and the state is responsible for public protection and safety of the of the public, and this serves as a national standard against which they can judge that competency. So I think it does serve as a protection for the patient. It certainly serves as a level of competency for the EMS provider. So.
Right, but it doesn't do anything. I mean, this individual's still going to take that state test regardless of National Registry or anything. The bottom line is they're going to have to take that state test. And if I'm not leaving the state, because I see things for joining National Registry, and I have students who people ask me about it, and I was like, well, if you're not leaving the state, you're still taking your state-approved course, you're not leaving the state. So what would be the purpose of the National Registry if you're not leaving your state? You're taking the state-approved paramedic course or EMT course or whatever, you're taking the state exam.
No, let me help you out with that. If, let's say, Wyoming doesn't use the National Registry, but if you go in there with a National Registry card, you don't have to take their state test.
Right. But what I'm saying, but you're staying in the same state. Like I'm in the state of ABC, and I'm never leaving it. I don't plan on going anyplace else. I'm staying here. So
Well, then your state may have adopted the National Registry because they understand the expenses and complications and development of valid, psychometrically sound, legally defensible exam. They may use our exam as their certification examination upon which is part of meeting their licensure requirements.
Right. So basically, at that point, you're providing a test to that state.
Right. And we're certifying the individual too.
Yes, sir.
I have kind of a two-part question. Mr. Brown, you said that the National Association of State EMS Officials named the National Registry as the National Testing Agency.
Yes, the National certification.
First of all, who are they to do that, since it's a states' rights issue and it's not NZIMSO's issue to deal with? And the second part of the question is to Mr. Dawson, does the federal government support this seemingly monopolistic kind of approach?
Let me just start off with just the education agenda. And in the education agenda, which was actually a consensus-based document, again, that was developed by the national EMS community, we were the conveners of the education agenda and brought folks together. And again, that included all the folks, including fire services organizations. The vision of that organization, and I would just read the vision, is that the National EMS certification, this is the vision for 2010, the collective vision of those organizations is that the National EMS certification will be conducted by a single independent national agency under the leadership of a board of directors with multidisciplinary representation. The single national certification agency will provide a consistent evaluation of recognized EMS provider entry-level competencies. It goes on, I have this if you'd like it. But so the vision of the collective vision of the national EMS community in the EMS education agenda was for a national EMS certification, is for a national EMS certification agency, and is for a national EMS accreditation agency. I'm sorry?
So the answer is yes?
The answer is the national EMS community, as we brought them together, said in the EMS education agenda that we want a national EMS certification, we want to be on a par with other EMS health professionals, and that we want a national EMS certification agency, single national EMS certification agency, and a single national EMS accreditation agency. The resolution from the National Association of State EMS Officials, and I would be happy to give you a copy of that, I also have that here, is they are the organization of state EMS officials, and the way that the EMS education agenda is written, it says it will be determined by the state EMS officials. So that resolution, which we'll provide for you, essentially is an endorsement of both the National Registry of EMTs and of the COAMPS as National EMS Certification and National EMS Accreditation Agency on behalf of the states. It still is a state, still the one who determines, an individual state, I'm sorry, is still the one who determines the individual state licensing requirements in an individual state. Just make that clear. Okay? Does that help?
Yeah.
And I've got both those documents if you'd like them. Okay. Other questions? It doesn't have to be about the education, Jen.
Does anyone know what the #1 cause of accidental death is in the demographic from 1 to 34 in this country? Come on. Vehicle crashes. We are looking at that at USFA really hard because we believe that the fire service has a lot of skin in those incidents. By that I mean we have a lot invested in terms of service delivery. If you look at the responders to these incidents and what they bring to the table in terms of lines of business, fire and EMS take on the lion's share of what's required there. By that I mean, in many cases you're directing traffic, making the scene fire safe, disentanglement, treatment, extrication, treatment, and in many cases transport, along with, in some cases, protecting the environment. So with all of those considerations, we believe that we should be playing a more active role. But when I say we, I mean the American Fire Service should be playing a more active role in terms of mitigation and prevention, partnering with other federal agencies such as DOT, NISTA, MAD, Mothers Against Drunk Driving, AAA, and the insurance companies. I believe we have a lot to offer. We're the only agency that responds to these incidents that's in every neighborhood. So I think there's an awful lot we have to offer. And what we're doing now is putting a program together and beginning to meet with IFF, IFC, and others to see if there's some level of interest in taking this on as an additional service to the citizens that we protect. Not a lot of burden hours, but I think it's an additional service that we can provide. It's also, of course, a risk to firefighters, and that's another piece of some of the studies that we've looked at, and our Arrival Life program that we partnered with IFF with and others. But we are very interested in that particular issue as we look at the number of fires that are each year. If you go back 20 years, they're down by around an average 7% a year. I think it was 33,000 people, and correct me, I defer to Dias here. I believe it's somewhere around 33,000 people died in vehicle accidents last year. We lost 3,000 in fires. So it is I think it's a growth opportunity for us, and it's one that we're looking at. I would be happy to hear your thoughts in terms of whether you think it's something we should get into. We're already into it, but I think in terms of bringing value, it is a growth opportunity for us. Clearly, mechanical firefighting, this is one man's opinion, which is worth what you pay for it, is that I don't think mechanical firefighting is a growth opportunity for us. The numbers of fires are going down. We're doing a great job. So I think for that reason, along with the fact that it's killing so many Americans, these vehicle crashes, they're no longer referred to as accidents, right? Because most of them are preventable. Does anybody know what the #1 cause of vehicle accidents?
Inattentive driving.
Yeah, distracted driving. And then, of course, #2 would be alcohol. You're under the influence of something, yeah. Exactly. And so, I think we can bring a really strong message and partner with others. It's just a thought I had. Any comments are welcome. If you disagree, I'd love to hear your thoughts, but because we don't want to go too far with this, and we're getting close to that. Yes.
Go ahead.
Following up on
Well, I worked in the Assistance to Firefighters Grant for 9 years, and one of the things we did there, realizing the data that you're speaking of, we moved converted vehicles to number one in terms of priority. In terms of the standards, of course, we work with NFPA for those standards. Are you speaking of DOT standards or NFPA standards?
No, sir. Recently, the NFPA new guidance specifically comes in and says heavy apparatus will be governed below a certain speed limit, regardless of the engine's capabilities, the vehicle's weight, etc. Obviously, we have a lot of different types of ambulances out there, 3 different class groups, various sizes. I'd like to see the NFPA break things down a little better for us with the heavy apparatus. But since you're dealing with the ambulances, and we do have a lot of multiple types of vehicles being used as ambulances, I don't think it's appropriate necessarily to have a blanket guidance, and I just wanted to see what your thoughts on that were.
Well, there's actually a separate standard you may be aware of that's under development with NFPA right now, 1917. That's the ambulance standard. And for those who may not be aware, the GSA, Government Services Administration, has had the federal triple K specifications for quite some time, and they're getting out of the business of ambulance specifications. But the point, two-part really is one, the GSA was never intended to be an outside the government standard. It was a purchase standard with buying ambulances within the federal government for tribal communities and military and other entities. It was adapted over decades by the industry with very little science behind the whole design of the ambulance as a whole. And so when the GSA was getting out of the business, they approached the NFPA to see if their interests. So to build upon, and your reference to 1901 being one specific reference therein, and the way it stands right now is on the NFPA 1917 itself, I think public comment is still open on the transition of the triple K specs, with the clarification being public comment on comments that were received from the first release of the document. So those commenting can only comment on the comments that were adjudicated already. For that, you can't comment on the whole document. I think I have that correct. NFPA's out the door down the hall. and Ken Holland is very familiar with that from NFPA. But the point being is what NFPA is trying to do with this right now is convert it into an ambulance standard that addresses type 1, 2, 3, and the big vehicles, and now the littler, smaller, modular type of ambulances that haven't received a category and the like, addressing the speed issues, the governance issues on the engines, etc., as well as the design. But in order to do that with their process, it takes quite a while, so they want to get this out, and it's in the 2012 cycle. So if it stays on the cycle the way it is right now, it will be published next year as NFPA 1917, and there'll be no more federal triple K specifications from that. However, unlike most NFPA committees, the 1917 committee will automatically continue. And what that essentially means is it will go into its immediate revision cycle where they can start to put evidence based behind everything in the ambulance for it. As some of the references that Chief Gaines made earlier of funding to NIOSH, a lot of things that Drew Dawson's shop does through NHTSA as SMEs to NHTSA's vehicular side of the operations, and a lot of other federal partners working together to make the ambulance itself safer, dealing specifically with an ambulance from whether a giant marshmallow in the side of the patient compartment is justified versus some other type of engineering controls on its design, et cetera, on every single component that's there. I know it's not directly addressing your question per se on 1901's heavy lift issue, although I think the caveat is 1901 is not governing ambulance construction at all, nor is it intended to. And I know 1917 is requesting more participation both ways, some of the SMEs on 1917 to 1901 and some of the SMEs from 1901 over to 1917 as they maturate the two design issues on these specially designed apparatus. So if that helps, just a general background as it applies to ambulance specifically.
So would it then be fair to say that whatever guidance we do get from 1917, regardless of whether it follows what they did with the other apparatus or not, that yourself and your colleagues up there, as the EMS group nationally, will probably follow with what the NFPA says, or do you anticipate developing your own set of recommendations and guidelines for manufacturers and operators?
From Homeland Security's perspective, we're deferring to the NFPA, I can tell you that, because the federal partners are working together. There are 4 federal agencies that serve on the NFPA committee. In fact, Drew Dawson, myself, you remember the NFPA, and there's Jim Green, who is with NIOSH, who is one of the scientists and engineers behind most of the crash study that's being done in the federal government perspective right now, serve on that committee. So we're not going to redevelop, at least to my knowledge, I can't speak for NHTSA, but we're not going to come up with our own standards. That's why we're working collaboratively with NFPA to say, look, this is the recommended one-stop shop.
At the same time, we're working with Jim Green and NIOSH and NIST and DHS and so on to try to gather more information to the next time NFPA 1917 is revised, so there's more scientific information and so on to feed into its revision. So, but we all are all working together on it for sure. That was kind of the idea from the beginning, so you bet.
The Department of Homeland Security, beginning actually, it's been 4 years ago, appointed a group of SMEs. I served as part of that group, original group, to identify NFPA standards the Department of Homeland Security should defer to. 1901 is one of those, so there will be no separate efforts to develop our federal standards.
With that, I think our time has come to a close. If I will be up here if you want to stop up and visit, or if any of you want to, be happy to do that. Feel free, or if anyone wants to, feel free. And thank you very much for participating today. Thanks a lot.